Here we are with news from the website prostatewarriors.com. The annual AACR 2026 meeting has just kicked off, and we already have some interesting studies to report on.
Yeah, it's a completely overwhelming volume of data coming out of the conference.
It really is. So welcome to this deep dive, everyone. Our mission today is to, cut through all that noise and highlight the absolute most critical breakthroughs in prostate cancer for you.
Right.
Because we are looking at some wild stuff. Drugs that literally throw cancer cells into the cellular trash can, and algorithms that can track a retreating tumor just by looking at the tiny DNA footprints it leaves behind in the blood.
Exactly. And, to honor your time as you're listening, we're going to stick to a very specific roadmap today.
Sounds good.
We'll prioritize human data first. So jumping straight into the clinical trials that are impacting patients right now, then we'll move into the intelligence layer.
The biomarkers, right.
Yeah, the predictive biomarkers showing how these drugs actually work on a genetic level. And finally, we'll pull back the curtain on the preclinical research that's frankly going to shape the next decade of care.
I love it. Let's start right on the cortical front lines then. Looking at how researchers are, refining our systemic arsenal, because this is really all about making existing strategies safer and more effective for patients who are running out of options. The phase 3 trial, HC 11-1904, is a perfect example of this.
Yeah, the Deutenzalutamide trial.
Right. Can you break that down for us?
Sure. So this is a robust phase 3 trial. It involved 417 patients with metastatic castration-resistant prostate cancer, or MCRPC.
Which is a tough spot to be in.
It's an incredibly tough spot.
Understood.
To really grasp the gravity of this data, you have to look at this specific patient population. These are individuals who previously failed abiraterone.
Okay.
And furthermore, 68% of them had also failed docetaxel chemotherapy.
Wow. So they have highly, highly aggressive disease.
Exactly. And in that group, Deutenzalutamide demonstrated a 32% reduction in the risk of radiographic progression or death.
That's massive.
It is. The hazard ratio was 0.58. To put it in absolute terms, the median progression-free survival extended to 5.55 months compared to just 3.71 months on the placebo.
Yeah, that is a really meaningful jump for a heavily pretreated group like that. But I have to ask about the overall survival data, because when you look at it, it seems a little murkier on the surface, doesn't it?
It does, yeah.
Like the final pre-specified overall survival analysis showed a hazard ratio of 0.95.
Right, and on its face, 0.95 is not statistically significant. But, and this is crucial, clinical trials in late-stage cancer are incredibly complex.
Because patients don't just stop getting treated.
Exactly. They rarely just stop. When researchers ran sensitivity analyses, basically adjusting the data to account for the fact that patients in the trial went on to receive subsequent taxane-based chemotherapy or other targeted therapies, a much clearer picture emerged.
Oh, interesting.
Yeah, the analysis hinted at a real-world survival benefit, pulling that hazard ratio down to between 0.65 and 0.73.
Okay, so the subsequent treatments were essentially muddying the waters. Like they were masking the actual survival benefit of the Deutenzalutamide in the raw, unadjusted data.
That is the consensus, yes. But, perhaps the most vital takeaway from this trial actually involves the safety profile.
Right, because of the neurological stuff.
Exactly. There were 0 seizures or falls reported.
0. Wow.
0. Older androgen receptor inhibitors, they're known to cross the blood-brain barrier, right? And that can lead to severe neurological toxicities, cognitive impairment, falls, seizures.
Yeah, which is terrifying for a patient.
Exactly. By completely eliminating those central nervous system side effects, this drug dramatically alters the quality of life equation for you as a patient.
That is such a big deal. Okay, so moving from hormone therapy over to DNA repair, we have some updated phase 1 data on a drug called ACE-106.
Ah, yes. The PARP inhibitor.
Right. It's a highly selective PRP1 inhibitor. And in a really heavily pretreated MCRPC population with homologous recombination repair mutations, it's showing, an impressive 50% objective response rate.
Yeah, a 50% OR in that specific mutant group. The overall ORR was 38%. And the mechanism here is what makes that response rate so important.
Because of the selectivity, right.
Precisely. Older first-generation pan-PARP inhibitors, they target both the PRP1 and PARP2 enzymes.
Right.
And While that effectively breaks down the cancer's ability to repair its DNA, blocking PARP2 causes severe collateral damage to the bone marrow.
Yeah, I was going to say the toxicity is awful.
It leads to dose-dependent hematologic toxicity,
Right.
meaning, the higher the dose you give, the worse the anemia and low platelets become.
So it's kind of like, think of the older pan-PARP inhibitors as a sledgehammer, right? Like it's a sledgehammer that shatters the cancer's DNA repair process, but heavily damages the bone marrow at the same time.
That's a great way to put it.
And ACE-106 operates more like a scalpel because it targets PRP1 but leaves PRP2 alone, so it avoids that sweeping collateral damage to the blood cells.
Exactly. We see the reality of that scalpel approach directly in the trial safety data. The hematologic toxicity did not increase as researchers escalated the dose.
That's incredible.
They found no dose-limiting toxicities and 0 grade 4 or 5 treatment-related adverse events.
0 again.
Yeah. This dissociation between the drug's concentration in the body and marrow toxicity is a massive operational win. It allows oncologists to maintain steady, highly efficacious dosing without the constant threat of severe cytopenias forcing them to, halt the treatment.
Right, because stopping treatment is when the tumor gets a chance to bounce back.
Exactly.
Okay, so ACE-106 protects the bone marrow by being highly selective, but what if we go the exact opposite route? Like, what if we decide to block absolutely everything?
You're talking about HSK 46575.
Yes. That brings us to another phase 1 trial evaluating this drug. It's a novel CYP11A1 inhibitor designed to suppress the entire steroidogenesis pathway.
Right.
And it resulted in a 30.8% PSA decline of at least 50%, a PSA 50. And it showed particular efficacy in patients who had androgen receptor ligand-binding domain mutations.
That's correct.
But, I have to push back on the underlying premise here. If this drug shuts down all steroid synthesis, meaning glucocorticoids, mineralocorticoids, sex steroids, everything, why aren't these patients experiencing massive systemic shock?
No, it's a vital question. CYP11A1 is the enzyme responsible for the very first step of steroid production. It converts cholesterol into pregnenolone.
Right, the absolute top of the cascade.
Yeah, so if you block that, you theoretically starve the body of every vital steroid hormone. You'd anticipate intolerable toxicity, maybe even adrenal crisis.
Exactly.
Yet the safety profile was surprisingly manageable. Only 7.4% of patients experienced grade 3 or higher treatment-related adverse events, and there were no dose-limiting toxicities.
But how? How is the body tolerating that massive upstream blockade?
It requires meticulous clinical management, primarily involving physiological steroid replacement.
Oh, I see.
You provide the patient with exactly the baseline steroids they need to survive safely, like a daily pill, but you completely shut down the runaway endogenous production.
So you turn off the factory and just ship in the essential supplies?
Exactly. And for tumors with mutated androgen receptors that survive by feeding on residual, locally produced steroids in the tumor microenvironment, destroying that entire upstream factory is highly effective.
That is fascinating. Starving the androgen receptors is a great strategy, assuming the cancer stays dependent on hormones. But we know tumors are, masters of evasion.
Unfortunately, yes.
What happens when the cancer completely changes its biological identity to avoid these drugs entirely? I'm talking about lineage plasticity.
Right, where the tumor essentially takes off its prostate cancer jacket and puts on a neuroendocrine jacket.
Exactly. Neuroendocrine prostate cancer, or NEPC.
Yeah, NEPC is an evolutionary escape mechanism. Once a tumor transitions to NEPC, which is often after prolonged exposure to hormone therapies and failing platinum-based chemotherapy, the clinical outcomes are notoriously bleak.
How bleak are we talking?
Progression-free survival is usually measured in just a few months, and historical response rates hover below 20%.
Man. Which is what makes the phase 1 trial data for ZL-1310 so crucial.
Yes, absolutely.
So this is a novel antibody-drug conjugate, an ADC, targeting a protein called DLL3. And DLL3 is incredibly useful here because it's highly expressed on the surface of these neuroendocrine tumors, but it's virtually non-existent on normal, healthy tissues.
Right. It creates a highly specific zip code for the therapeutic payload.
A zip code, I like that.
And in this trial for advanced neuroendocrine carcinomas, including that really aggressive NEPC subset, ZL-1310 demonstrated a 48% objective response rate.
A 48% response rate in a cancer variant that typically just ignores second-line therapies. That is a massive beacon of hope.
It really is.
And the engineering behind the drug is fascinating, too, because it utilizes a tumor microenvironment activatable linker, So it doesn't just circulate and randomly drop its toxic payload everywhere.
Right, it relies on the specific chemical conditions found only near the tumor.
Right.
The linker is designed to remain stable in the bloodstream. But once it reaches the highly specific, often acidic and enzyme-rich environment of the tumor, the linker cleaves.
And drops the bomb.
It then drops its payload, which is a topoisomerase I inhibitor, that physically prevents the cancer cell's DNA from unwinding and replicating. It drops it directly into the target.
That is so smart.
Seeing these profound responses, even in patients who had previously received other DLL3 targeted therapies, really suggests that this particular linker-payload combination can overcome existing resistance mechanisms.
Okay, so if tumors are so adept at changing their identity to evade systemic hormone drugs, maybe we stop playing their game entirely.
What do you mean?
Instead of starving them, what if we just deliver high-grade radiation directly to their doorstep, like the data from the phase 1 trial of 225 ACJ591?
Ah, yes. Utilizing the alpha-emitting isotope actinium-225.
Exactly. And what differentiates this therapy is the delivery vehicle, right?
Yeah. It uses actinium-225 linked to a PSMA-targeting antibody. Most approved radioligands use small molecules, which have very rapid pharmacokinetics.
Meaning they move fast.
Right. They dart into the bloodstream, bind to the tumor, and the excess is quickly cleared by the kidneys. But an antibody is much larger. It moves slower, circulates longer, and delivers the radiation payload over a prolonged period.
But the critical insight from this trial actually revolves around the dosing schedule.
Yeah, that was a big surprise.
Because researchers tested a standard schedule against a fractionated schedule, where the doses were divided up and given closer together. And the fractionated schedule was vastly superior.
Completely superior. 68% of patients achieved a PSA decline of over 50%. Progression-free survival reached 5.2 months, and overall survival hit 15.4 months in heavily pretreated patients.
Wow. And the divergence in outcomes is based strictly on the administration timing.
It is profound, yeah.
Yeah.
The standard schedule struggled largely due to hematological side effects. Delivering massive, infrequent doses of radiation suppresses the bone marrow, causing a sharp drop in platelets.
Oh, so they have to wait longer between doses.
Exactly. This forces clinicians to delay subsequent cycles, which hinders the therapy's momentum and gives the tumor time to recover.
So the standard dosing acts like a single massive haymaker punch in a boxing match. It strikes hard, but it leaves the patient's bone marrow completely exhausted, and they require a long recovery period before they can take another swing.
That's a perfect analogy.
And the fractionated dosing operates like a calculated 1-2 punch. It keeps the tumor constantly on the ropes while allowing the patient's bone marrow to recover between the later strikes.
That aligns perfectly with the clinical observations. Now, sticking with alpha therapies, the phase 1 trial for 211 at PSMA-5 introduces astatine-211.
Right.
And the clinical responses seen here were extraordinarily rapid. Pelvic recurrences resolved after just 3 cycles, and bone and lymph masses vanished within 4 weeks of the final dose.
The tumor shrinkage is incredible. But the actual breakthrough with astatine-211 extends far beyond the clinical responses, doesn't it?
It does. It solves a massive logistical crisis in nuclear medicine.
The supply chain issue.
Exactly. The supply chain is the bottleneck of modern radioligand therapy. Actinium-225 is notoriously scarce globally. It relies on the decay of legacy nuclear material, making it incredibly difficult to produce in the sheer quantities required to treat the global prostate cancer population.
But astatine-211 completely bypasses this limitation.
Yes. It is produced domestically in cyclotrons by bombarding highly abundant bismuth targets with alpha beams.
You essentially bypass the international nuclear supply chain and manufacture the isotope on demand locally. That's huge.
They're achieving a 30% radiochemical yield through this process. It produces sufficient material for reliable clinical supply without relying on imported scarce isotopes.
So it turns widespread access to alpha therapies from a theoretical goal into an actual reality.
It's a fundamental logistical triumph.
But, okay, we have these incredibly powerful radioactive drugs delivering radiation directly to the tumors. These are intense systemic therapies. How do doctors ensure they're giving them to the patients who will actually survive and benefit, rather than those who will only absorb unnecessary toxicity?
Patient selection is arguably the most critical challenge in advanced oncology right now. Which brings us to the intelligence layer of the conference, the observational biomarkers.
Right. There's a new observational study tracking 140 patients treated with 177 Lu PSMA-617, commonly known as Pluvicto.
Yes. And instead of relying solely on PSA levels, The researchers utilized whole genome sequencing on liquid biopsies.
Just simple blood tests.
Simple blood tests, yeah. To analyze circulating tumor DNA, or ctDNA.
They utilized a computational framework called Proteus, right? Which relies on a field called fragmentomics.
Fragmentomics, yes.
Because instead of just looking for mutations, Proteus infers how the tumor is behaving based entirely on the specific lengths and fragmentation patterns of the DNA pieces floating in the bloodstream.
It's really mind-blowing.
I compare it to reading the exhaustion, the health, and the precise tactics of a retreating army just by analyzing the specific depths and shapes of the footprints they leave behind in the mud. Like, you never actually see the soldiers, but the footprints tell you exactly what they're doing.
That is exactly what they're doing. And that framework revealed critical survival data. Initially, they found that a high baseline fraction of ctDNA in the blood correlated with significantly worse survival.
Really?
Yeah, it carried a hazard ratio of 2.19. This proved to be a much more accurate reflection of the true systemic tumor burden than PSA alone. But the genomic data provided even deeper insights. They discovered that patients with mutations in the ATM gene actually experienced longer survival times on Pluvicto.
Which feels counterintuitive until you look at the mechanism.
Right.
Because ATM is a gene heavily involved in repairing damaged DNA. If the tumor's ATM gene is mutated and broken, the cancer cells lose their ability to repair the massive double-strand DNA breaks caused by the radioactive drug.
Exactly. The mutation becomes a fatal vulnerability for the tumor.
It creates a perfect synthetic lethality.
Yes. Conversely, patients who exhibited amplifications in the MYC oncogene face significantly worse outcomes.
Because MYC is a driver, right?
Right. The MYC gene is a master regulator that drives rapid cellular proliferation and therapeutic resistance. By reading these genetic footprints, we are moving away from guessing who might respond.
Right. We are predicting the exact molecular reaction a tumor will have to radiation before the first drop of the drug even enters the patient's vein.
It's precision medicine at its finest.
Okay, so we've explored the clinical trials and the tracking tools. Now, let's peer into the lab to examine the preclinical horizon.
My favorite part.
We're looking at the foundational research that will dictate the next 5 to 10 years of care, specifically focusing on how to completely outsmart tumor resistance. Because the core problem with drugs like enzalutamide is that tumors adapt, right?
They always do. When we block the androgen receptor's ligand-binding domain, the cancer simply mutates that domain. Or it creates splice variants, like ARV7, which literally lack the domain the drug is designed to target.
The cancer effectively builds a receptor without a keyhole, rendering our conventional keys entirely useless.
That's a perfect visualization. And this is where a compound called ITRI-148 enters the picture. It bypasses the traditional binding sites entirely.
Where does it go?
It binds to the N-terminal domain, a region of the receptor previously considered completely undruggable due to its disordered structure.
Oh, wow.
And more importantly, it utilizes a PROTAC mechanism.
So instead of just blocking the receptor, it triggers a process to destroy it.
Exactly. By binding to the receptor, ITRI-148 recruits an E3 ligase called cereblon.
Cereblon, okay.
Yeah. In cellular biology, E3 ligases are essentially the sanitation workers of the cell. They attach a tag to defective or unnecessary proteins. Once the androgen receptor is tagged by this PROTAC, the cell's own waste disposal system, the proteasome, grabs the receptor and shreds it.
That's brutal.
It actively degrades the ARV7 variant entirely.
It is a profound shift from passive inhibition to active destruction. But researchers are also developing another approach called Helicon peptides, right?
Yes.
Because existing therapies and even some degraders typically target the inactive form of the androgen receptor. Helicon peptides are designed to hunt down the active agonist-bound receptor, what is known as ARON, right, at the AF2 coactivator site.
They do. It degrades the very receptors that are actively driving the cancer's transcription at that exact moment.
But, and I have a question here. If Helicon peptides only destroy the receptors that are currently active and driving the cancer, what stops the tumor from just stockpiling thousands of inactive receptors, keeping them quiet, and simply outlasting the therapy?
That is a brilliant question, and it's the exact vulnerability researchers anticipate, which is why these degraders will not be deployed in a vacuum.
Oh, combination therapy.
Exactly. The clinical strategy hinges on combination therapy. You utilize a standard inhibitor to trap the bulk of the receptors in their inactive state.
Okay.
Simultaneously, you deploy the Helicon degrader to actively clear out the pool of receptors that manage to activate and attempt to drive resistance.
So you attack the cellular machinery from both ends, engineering an inescapable molecular trap.
You've got it.
Incredible. While targeted degraders are incredibly elegant, there's also a push toward engineering complete cellular chaos inside the tumor.
Cellular chaos. I love that phrasing.
Let's examine a Nano-PROTAC currently in development. It carries the lengthy designation ARV at mil-H-SSSHA.
Yeah, quite a mouthful. But beyond the complex nomenclature, the underlying mechanism is astonishing. It merges targeted protein degradation with a distinct biological process known as ferroptosis.
Ferroptosis, right.
The researchers utilize an iron-based metal organic framework called ALL-101. This framework serves as a carrier to deliver a specific PROTAC called ARV-771 into the cell.
The delivery mechanism operates like a microscopic Trojan horse. It relies on a hyaluronic acid coating to sneak into the cancer cell via CD44 receptors, which are overexpressed on the tumor surface.
Yeah.
Once inside the cell's environment, the framework breaks apart. It drops the PROTAC bomb, which immediately goes to work destroying the BRD4 protein, crippling the tumor's crucial growth signals.
Right.
But the brilliance is in the delivery vehicle itself. The iron carrier doesn't just dissolve harmlessly.
No, it doesn't. The iron carrier acts as an enzyme. It reacts with the hydrogen peroxide naturally found inside the cancer cell to generate highly toxic hydroxyl radicals.
Wow.
This massive spike in oxidative stress triggers iron-dependent cell death, or ferroptosis.
So it destroys the tumor's blueprints by degrading the proteins and simultaneously burns down the entire building by triggering oxidative collapse.
It delivers dual-mechanism lethality. If a subpopulation of cancer cells somehow manages to survive the protein degradation, the cascading oxidative stress from the ferroptosis ensures the cell cannot recover.
And has it been working?
It has proven highly effective at overcoming resistance mechanisms in preclinical cell models.
Amazing. Okay, let's round out the preclinical data with next-generation immunotherapy. T-cell engagers have traditionally had a very rocky history in solid tumors because they trigger massive systemic immune responses.
They do. Cytokine release syndrome and severe off-target toxicity have halted many promising immunotherapies.
Right.
However, a new compound called ProTCE-PSM is designed to widen the therapeutic window safely. It utilizes a multiprotease activatable linker.
So another smart linker?
Exactly. The CD3 binding domain, the specific component that activates the patient's immune T cells, remains dormant in the bloodstream. It only activates when exposed to the highly specific mixture of enzymes found exclusively deep within the tumor microenvironment.
This precision targeting resulted in a 10-fold lower cytokine release compared to older models like JNX007. It directs the immune system's fury strictly at the tumor, sparing the rest of the body.
Exactly.
And finally, there is AM109, a bispecific antibody targeting PSMA on the tumor and CD137 on the immune cells.
AM109 shifts the focus from direct T-cell recruitment to localized co-stimulation.
What does that mean in practice?
Well, by engaging CD137 selectively at PSMA-expressing tumor sites, it effectively converts a normally immunosuppressive cold tumor microenvironment into a highly reactive hot one.
Oh, that's huge.
In Reen models, it achieved complete tumor regression at vanishingly small doses, just 0.1 to 0.3 milligrams per kilogram. It promotes long-term, tumor-specific immune memory without triggering systemic immune panic.
We have covered a massive amount of highly complex ground today.
We really have.
Yeah.
But if there's one overarching concept to take away from this data, it's that we are observing a massive paradigm shift in the fundamental philosophy of oncology.
How so?
For decades, standard practice relied on blocking cancer pathways with static inhibitors, essentially a biological game of whack-a-mole where the tumor always eventually adapted.
Right.
Now, by utilizing PROTACs to drag rogue proteins to the cellular trash, engineering nanozymes that trigger iron death, and relying on fragmentomics to read DNA footprints in real time, we are treating cancer not as a static mass, but as a dynamic, programmable algorithm.
A programmable algorithm.
Yes, we're developing the tools to actively outcode the tumor and trick it into dismantling itself.
The concept of treating cancer as code that we can actively rewrite is profound. I highly encourage you to keep exploring the literature on lineage, plasticity, and fragmentomics, as those concepts are absolutely going to dictate the clinical advancements of the next decade. We are moving from blunt systemic instruments to highly programmable, intelligent molecular warfare.
The pace of innovation presented here demonstrates that the future of targeted oncology is incredibly bright, and the momentum is only accelerating.
Stay strong and fight on.